First of all, thank you very much for the kind introduction. And I would like to thank the teams in India for the invitation. It's great to be part of the venue here. They made the travel very easy and comfortable as well. So my talk is on conventional knee replacement, mission impossible. So how to move this? What is it? So just technical issues. So I think it's not mission impossible, but I have to agree it's very difficult. Why it's difficult? Because you have to match one compartment to the rest of the knee. Each knee is different morphology, and you have to do fine-tuning in terms of performing your bone cuts. You have to remember in partial knee replacement, you do minimal or no soft tissue release, so you're relying on your cuts. And early reports showing high failure related to overcorrection or undercorrection. So you could easily put your tibial cut into varus or valgus, or you can change your slope or decrease your slope, or you can change also rotation. The same thing goes for the femur. So that's very demanding when you're performing conventional cuts with the conventional jigs. It's very easy to edge load, which will lead to failure and also increase wear. Also, overhang is an issue. So if you are in the tibia, you are not allowed to overhang medially more than 2 millimeters, posteriorly no more overhang than 3 millimeters, and anteriorly no more than 5 millimeters. In the femur, posteriorly, you're not supposed to overhang more than 5 millimeters, otherwise this will compromise your results. How about this slot? If you're using a mobile bearing, then you have to keep a space mediolaterally for the bearing to slide. You have to make sure that they are basically nicely aligned and the femur slightly more lateral to avoid loading your bearing and leading to spit out or wear. So you have to do all of this with these conventional jigs. So this is showing conventional jigs. So the difficulty just being alluded by Dr. Vadia is how to basically find the center of the hip when everything is draped. How to find center of the ankle when you have a very obese patient. So this places a lot of challenge on the surgeon to get everything based on visual inspection without having accurate numbers to use. So when you're doing your rotation, which is very important to get the rotation right, you have to aim your jaw, as I say, your saw blade just directly to the center of the head, of the hip, which is very difficult to do. And then get the sloping. It's very important not to raise your hand, otherwise you cut posteriorly, and that will cause also a risk of fracture. So there is a lot of pressure to perform well. When you're using this jig, one of the problems using this jig, when you put this intramedullary, it pushes your femoral cut into valgus and slight flexion, so it's important to pay attention to that as well. And also this jig based on the flexion, your tibial cut. So if you made a mistake in your tibial cut, this will also translate into the femur. If we look into this study showing that in 101 knees done post-CT after by Aragon in Journal of Knee 2014, with the 71 months follow-up, he showed better clinical results when you have less external rotation. So that is very important to also not to miss your femoral rotation because that will compromise result and survival. However, partial knee replacement, when it's done well, it's very good because you're preserving soft tissue and bone for future revision. It's always easier to revise a uni to a total than revising a total to revision total. We all know based on all these results in the journal that they have better reported, patient-reported pain scores, better functional and forgotten joint scores, better restoration of joint line and gait pattern. They have less hospital stay, less transfusion rate, less 30-day hospital stay. At the same time, you're decreasing complications such as comorbidities and mortalities. And this being shown also in articles. If we look into large case series of the designers and non-designers, you will see that survival is fantastic. You're talking about 96% survival, about 10 years. But the problem comes in the registry. When you go to the registry, you will see high failure rate approaching anywhere about twice that of total knee replacement and about 20% if you look into the Australian registry. So what are the reasons these revision rates are high? First of all, it's very easy to revise a uni to a total than revising the total to a revision. And we can see in this study by Goodfellow at JBJS 92, he looked into Oxford knee score, all patients with less than 20 score in the Oxford knee score, which translate to a poor outcome. Only 12% of those were revised from total knee group versus 63% from the uni group. Another factor for high revision, you're operating, remember, on younger patients, so they are more active, high demand, they're more likely to wear, so they're going to have a higher revision rate. Last but not least, a surgeon-related factor. Most of the numbers in the registry for number of cases per year, the highest was 1 case a year, and the second common number was 2 cases per year. So there is a lot of learning curve that need to be done, which is missing here, and this is a very difficult operation to do, so you need to have a high learning curve, and you have to do a higher volume to decrease, just been shown by Dr. Ashok's studies and the paper that he showed in the earlier slide. So I think selection criteria is very important when it comes to a partial knee replacement, and I think this is key. A lot of the surgeons follow the classic indications by Cousin and Scott. So you have to have an isolated medial compartment, intact both cruciates, no angular deformity more than 15 degrees, no flexion contracture. You have to have more than 90 degrees of flexion, less than 5 degree flexion contracture. And what's very important, so if you look into patellofemoral arthritis, no patellofemoral osteoarthritis, age less than 60, weight less than 82, and low activity level. So if you strictly follow this selection criteria, you're going to operate less than 5 to 10% of your volume of cases. And this is where the problem comes. So if we look into patellofemoral joint, I think it's a controversial issue for a lot of the years. If we follow Goodfellow paper in Core 1986, he found that PFJ damage did not compromise outcomes. If we look into recent publications by Pandit, he showed patients who had anterior knee pain, he did a uni, their actual knee pain improved and disappeared. They looked into the cartilage defect in the medial facet, and they found basically if you have a cartilage defect only in the medial facet, it was not a negative prognostic indicator, and actually patient had an excellent outcome, no different compared to those who didn't have a cartilage defect. The only negative indicator that you have to follow is lateral facet osteoarthritis or central osteoarthritis at the patella. So this is one contraindication that I follow if they have a lateral facet osteoarthritis. How about age? This is another study showing basically age is not a problem. You don't need to be adhering to those patients who are very young. It's actually a much better operation to do in older patients who are unfit because it is associated with less complications and comorbidities and mortalities. And this is being confirmed by Price and Liddell. This study shows here, if you follow the graph, it shows basically survival at 15 years between both groups, less than 60 and above 60. There was no difference. How about activity level? Murray showed in his presentation at the London meeting, patients with increased activity actually have a better survival at 12 years, and they have a better Oxford knee score. If we look into very active people, Tegner 5 and plus, those are heavy laborer with jogging on uneven ground, and if we look at their survival at 12 years, it was 97.3, and their Oxford knee score was 45. Obesity, again, obesity, they looked into 2,500 knees, followed them up for 12 years, and what they found that survival was independent of obesity and weight. However, the Oxford knee score was less as their weight is increasing. But if we look into the percentage of improvement of their Oxford knee score, as their weight is increasing, actually, they improve better. So if we look at this slide, the second bar, looking at the BMI, as the BMI is going pre-op, they have the lowest Oxford knee score to start with, but then post-op, they have the higher percentage change afterward. There are other authors who confirm the same thing. So obesity is not a contraindication. I think you have to adhere to the indication and then away from the contraindication, which are infection, inflammatory, ligamentous instability, MCL contracture, previous HTO, and lateral facet joint osteoarthritis, lateral compartment osteoarthritis. Surgeon-related factor related to two factors, either selection problem or technical issues. And I think they work hand in hand. So if you improve your selection criteria, and bring it more than 20%, then your technical skills improve better, and then your revision rate goes down. And this has been shown by Liddell paper in JBJS 2016. He showed low-volume surgeons had 4 times higher revision rate than high-volume surgeons. And the same author showed that if your partial knee replacements are more than 20% of the volume of your practice, then you're going to have an acceptable rate of revision and complication. And the optimal results were used when you have a 50% usage. If you go beyond 50, this means you are overcalling it and you are overdoing it, and then they have a higher revision rate. So improving selection criteria really helps. The same thing being confirmed by Hamilton, Journal of Arthroplasty, 2017. He did this meta-analysis that shows if you do more than 20% of your case volume, you had lower revision rate, regardless of your caseload. Let's say you're doing 50 total joints a year, and you're doing only 5 partial knees, so you're going to have low result. But let's imagine you're doing 50 total joints, but you're doing 20 out of 50, 20% of the joints that you're doing are unis. Therefore, you're going to have a lower complication rate. So this reflects, again, the indications more important than the caseload. This is an example of the first case I've done. So you could see basically the cuts are okay in terms of varus valgus, the femur nicely centered, and the overhang, however, in the femur posteriorly. So the problem with this device is it's very hard to get pre-op templating because you cannot get a perfect lateral to do your templating. So you're relying on your intraoperative sizing. And I find with the Oxford knee, it's very difficult to do intraoperative sizing. And a lot of it has got to do with estimation. Is the patient above 170 centimeter, then he's going to be large. If he's less than 165, he's going to be medium. If he's less than 155, he's going to be small. The problem with Asian knees is difficult because we have a large medial lateral compared to the AP, and sometimes that becomes an issue. So I found that with the Oxford knees, it's difficult to get the sizing right. So I got more courageous and started doing my second case. I just started doing unis from last year. Looking at this X-ray, we could see again that we are not as lateral as we want to be on the tibial cut. My femur is more medial than it's supposed to be. It should be a little bit more lateral. However, sizing is better. This case came in with the medial compartment that is correctable at 30 degrees and no anterior knee pain. Lateral is intact. So we went ahead. We did the bilateral uni. Patient did well, but criticizing this image, the tibia is slightly valgus. It could have been a little bit more lateral, just abutting the lateral medial edge of the medial eminence. On the left side, we did better. However, I could have been a little bit more lateral on the medial femoral component to make it perfect. So you can see the difficulty of getting reproducible results. Some X-rays are good, the other one is not. The one that really bothered me looking at this one, I mean, I thought coming out of theater that my femur, my tibia is just perfect fit. But looking at the lateral here, I have to say this is not perfect lateral, but looking at those X-rays got me really worried for 1 month of just thinking it's going to fracture, what's going to happen. So this is another patient who came in, 65-year-old, and I thought, you know what, I don't want to go with Oxford because of that sizing. I want to use a Journey, so I went ahead and used Journey. I have to say Journey uni is more user-friendly in terms of sizing, matching your tibia, femur. You can match all sizes, and your bone preparation and cuts are much easier. It's a fixed bearing, so you don't worry about spit out of the bearing. But it is still challenging because you're the same factors. You're using this conventional jigs to find center of the head, center of the ankle, and then getting the rotation. So you're controlling 3 planes of cuts using conventional jigs. I have to say it's very hard. Since then, I switched to using robotics, and our next speaker will talk about robotics, partial knee replacement. So in conclusion, a partial knee replacement, very rewarding surgery, but it is technically more difficult than conventional. It's very important to improve your selection criteria, to do more than 20% of your volume to get the revision rate low. I have to say age is not a problem. Activity level is also should not be looked into. Obesity and medial facet of the patella should be ignored. Since I've done that, I started doing about 20% of my practice now is uni, using robotic assisted, and I've been very happy because uni patients are your best advocates. They leave the hospital quicker, they get there quicker, And that really builds up a reputation of total joint replacement for you, either total, partial, patellofemoral, because patients are really happy. So thank you very much for your attention.
Thank you, Dr. Ali.